Hi, my name is Captain Schellebarger, and I'm a student at the United States Army Graduate Program in Anesthesia Nursing. And this is a presentation on the drug lidocaine. Lidocaine is available in a variety of formulations, typically seen in concentrations of 0.5%, 1%, 1.5%, 2%, 4%, and 5% solutions for injection. Lidocaine is a weak base with a pKa of 7.9. This means that if lidocaine were injected into a tissue with a pH of 7.9, half of the drug would combine with positive ions and become ionized or charged, and the other half would remain unionized. The average physiological pH of human tissue is 7.4. When lidocaine is injected into the body, a greater fractional percentage of lidocaine becomes ionized, leaving only a small percentage unionized. Because these unionized molecules of lidocaine are lipophilic, they easily cross the lipid membrane of cells. Once inside the cell, lidocaine again becomes ionized. It is this intracellular ionized fraction of lidocaine that binds to the inside of sodium channels on the sixth segment of domains 1, 3, and 4. This blockade inhibits the inward sodium current, thereby decreasing or blocking the rapid depolarization of nerve cells during inaction potential. As sodium channels open and close, they have three conformational shapes: resting, activated, and inactivated. Lidocaine shows a preference for the activated and inactivated conformations. These conformations predominate in areas with a more positive membrane potential. Thus, lidocaine's effects are greatest when nerve fibers are firing rapidly. The anesthetist uses lidocaine in a variety of ways on different patient populations. For spinal anesthesia, lidocaine 5% with 7.5% glucose is commonly supplied and should be diluted to 2.5% with opiates or CSF prior to injection with a total dose not exceeding 60 milligrams. This dilution is recommended to decrease the incidence of transient neurological symptoms, a condition characterized by prolonged lower back and leg pain after neuraxial administration of lidocaine. For epidural anesthesia, a lower concentration with larger volume is indicated. A 1% to 2% concentration is typical, and a general rule is that each 1 to 2 milligrams of lidocaine by epidural will cause one dermatome of pain sensation to be blocked. The volume is adjusted up or down to reach the desired level of sensory blockade. Lidocaine for IV can be given prior to induction of general anesthesia to blunt the stress response to intubation with a dose of 1 to 1.5 milligrams per kilogram. When lidocaine is given emergently to treat ventricular arrhythmias and ectopy, a dose of 1 to 1.5 milligrams per kilogram is also used. Lidocaine is the drug of choice for IV regional anesthesia, such as a beer block. 50 milliliters of 0.5% lidocaine is used for a total dose of 250 milligrams. Lidocaine is the local anesthetic of choice for these procedures due to its relatively fast onset and wide therapeutic index. For regional anesthesia with a peripheral nerve block, concentrations of 0.5 to 2% are common. Exact concentrations and dosing is highly variable and depends on the needs of the patient and the type of nerve block being performed. The toxic dose of lidocaine is 4.5 milligrams per kilogram, or 7 milligrams per kilogram when combined with epinephrine. A max total dose should never exceed 500 milligrams. For spinal anesthesia, the onset of lidocaine is typically 3 to 5 minutes. For epidural anesthesia, the onset is slightly slower at around 10 to 15 minutes. When used for regional anesthesia, lidocaine is considered to have a rapid to moderate onset of action. Intravenous injections of lidocaine onset within seconds and reach peak effect in 3 to 5 minutes. For spinal anesthesia, duration of anesthetic effect is 1 to 1.5 hours when given without epinephrine. Epinephrine does not significantly prolong the duration of effect for spinal use. Epidural anesthesia lasts slightly longer, with approximately 2 hours for plain and 3 hours when epinephrine is added. For IV injection, duration of action is approximately 15 to 30 minutes. When used in IV regional anesthesia, the anesthetic effect will remain as long as the tourniquet is inflated. Deflation of the tourniquet rapidly reverses the block and sensation quickly returns. Lidocaine for peripheral nerve block lasts approximately 1 hour when given without epinephrine. When combined with epinephrine, duration of effect may lengthen up to 3 hours. Lidocaine is in the amide class of local anesthetics and is metabolized by the P450 system in the liver. For IV injection, the metabolism half-life is 1.5 to 2 hours with complete elimination in approximately 9 hours. Liver disease can significantly prolong the metabolism or duration of action to 2 to 3 times more than normal. Time for near complete elimination of the drug can be up to 24 to 36 hours in patients with liver disease. Lidocaine has many uses to the anesthetist. Classically, it has been used as a local anesthetic to block pain impulses. For spinal anesthesia, lidocaine remains a good choice for rapid onset and short to moderate duration of action. It produces an excellent sensory block with strong motor block, coupled with a relatively quick recovery, making it an excellent choice for ambulatory surgery. However, it has also been linked to transient pain in the back, buttocks, and lower extremities. This has been termed transient neurological symptoms, and has decreased lidocaine's use for routine spinal administration. Diluting concentrations to 2.5% with opiates or cerebrospinal fluid prior to injection and limiting the total dose to 60 milligrams may prevent these injuries. Lidocaine's quick onset makes it a good choice for epidural injection in certain patient populations. It is frequently used in obstetrics for this reason. Lidocaine is commonly used in the operating room as a premedicant to blunt the pain of IV induction agents and to blunt the stress of laryngeal intubation. Patients with coronary artery disease may experience ischemia from the sympathetic-mediated increase in heart rate that follows from direct laryngoscopy. Patients with reactive airway disease are more prone to experience bronchospasm or laryngospasm from stimulation of airway reflexes due to manipulation of the airway during intubation. Patients with increased intracranial pressure or decreased intracranial compliance may suffer neurological symptoms from the rise in intracranial pressure that accompanies intubation. A dose of 1.5 milligrams per kilogram given 3 to 5 minutes prior to laryngoscopy may be effective in preventing these complications. The use of propofol as an induction agent has become common practice among anesthesia providers. The burning sensation of a fast intravenous injection of propofol may aggravate or produce unnecessary anxiety. A mix of 2 milliliters of 1% lidocaine and 18 milliliters of propofol can be used to blunt this burning sensation and smooth induction in some patients. Lidocaine can also be used to treat ventricular arrhythmias. Irritated cells in the myocardium depolarize and repolarize at a faster rate than healthy cells, spending more time in the active or inactive configurations. Lidocaine preferentially binds to sodium channels in these configurations. This explains why lidocaine selectively inhibits ischemic myocardial tissues without significantly affecting healthy myocardic tissues. Lidocaine, when used in appropriate doses, has no significant contraindications. Higher doses of lidocaine than those typically used in epidural anesthesia may manifest neurological symptoms. Symptoms of early toxicity include tetanus, dizziness, and perioral numbness. If a large intravascular dose of lidocaine is accidentally given, symptoms may include slurred speech, muscle twitching, seizures, and eventually respiratory arrest. Lidocaine depresses the myocardium in a dose-dependent manner. By blocking voltage-gated sodium channels in the heart, lidocaine slows the rate of depolarization and reduces contractility and conduction velocity, eventually leading to cardiac arrest. Major cardiovascular effects require 3 times the blood concentration required to produce seizures, and thus are not often seen. The anesthetist needs to be aware that intravenous doses of lidocaine can potentiate the effects of non-depolarizing muscle relaxers, prolonging their effects.